Hello, everyone. Good morning, good afternoon, or good evening, wherever you are joining us from. I'm Rahel Nardos, Associate Professor in the Division of Female Pelvic Medicine and Reconstructive Surgery, and Director of Global Women's Health at the Center for Global Health and Social Responsibility at the University of Minnesota. I'll be moderating today's webinar. We are so excited to welcome you to this event today, entitled Leveraging the Wisdom of Communities for Reproductive Health. This event is part of the 2023 University of Minnesota International Women's Day series, Embracing Equity and Justice in Reproductive Rights. The webinar series is co-sponsored by multiple centers within and outside of the University of Minnesota that are part of our Women's Health Equity Empowerment and Leadership Consortium called WHEEL, and also the Department of the Chicano and Latino Studies and the Department of Spanish and Portuguese Studies, and we're very grateful for these partners. We have an excellent panel discussion for you today. As we hear from our speakers, please submit any questions using the Q&A button below. The chat function is disabled. This is a 1 hour and 15-minute program, and we will leave about a half an hour at the end of this presentation to respond to your questions. Our program today is in both English and Spanish. You can change your preferred language using the button that says interpretation at the bottom right of your Zoom menu and select English or Spanish. And if you're using cell phone, then you'll have 3 little dots at the bottom of your phone that you can use to select the language you need. So today we have 3 incredible panelists who will share their inspiring work to mobilize global communities, influence policymakers through evidence, and connect people seeking abortion care with information and resources during their difficult journey. You can read their full bios on our website, and I think the link is going to be sent to you in the chat as well. So the first panelist is Abigail Eichen. She's an associate professor at the LBJ School of Public Affairs at UT Austin. Her research focuses on the impacts of law and policies restricting access to abortion, including how and why people self-manage their own abortions outside of the formal healthcare setting. She is currently the lead investigator on the Project SANA, a research project that examines self-managed abortion in the United States. And then our second panelist, many of you may have heard of Veronica Cruz Sanchez. She's a personal hero of mine. She's been a feminist activist in Mexico for more than 3 decades. She has extensive experience promoting social women's movements in Latin America. She has promoted the construction of accompaniment networks for safe medical abortion at home and around the world. She's the founder of the Las Libres Center for Information on Sexual Health. She currently works as a coordinator of the feminist advocacy area of Las Libres. And then last but not least, Joanna Hatch has worked in full spectrum of reproductive health care over the last 10 years in Dane County, Wisconsin. Her professional background includes advocacy, nonprofit leadership, and clinical care. Joanna serves as the founding president and administrative and collaboration coordinator of the Pregnancy Options Wisconsin Education, Resources, and Support Incorporated, also known as POWERS. So welcome to our panelists. We are so excited to have you. And before we begin this discussion, I like to start with a bit of context about where we are today regarding reproductive rights in the US and why this conversation is so timely and critical. So, last summer, most of you know that Roe v. Wade was overturned in the Dobbs decision. Roe v. Wade was passed back in 1973, in which the US Supreme Court ruled that the Constitution of the United States conferred the right to choose to have an abortion. But in June 2022, in the case Dobbs v. Jackson Women's Health Organization, this was overturned. This means it will be up to each state to essentially establish laws protecting or restricting abortion in the absence of a federal standard. As of now, there are over 30 states in the US who either ban or restrict abortion care, making it necessary for people in those states to seek services outside of their own state's care infrastructure. This means either traveling to other states or seeking assistance from outside organizations that can provide the care remotely. This barrier to care disproportionately affects people from marginalized and minoritized communities who may not have access to financial or other resources to seek this care. Here are a few facts from the Kaiser Family Foundation to give some context to today's programming. So more than half of abortions in the US are among women of color. Over 4 in 10, which is about 43% of women between the ages of 18 and 49 living in the states where abortion has become or will likely become illegal are women of color. Women of color are more likely to be low income, less likely to have savings to cover the cost of abortion, and less likely to have access to vehicles to drive to neighboring states to seek abortion care. They're also more likely to lack resources to access online healthcare information. The vast majority of abortions across racial and ethnic groups are in the first trimester, with less than 10% of abortions happening in the second trimester. And finally, in a survey of reproductive age women, the majority of women of all ethnic groups think that getting an abortion should be a personal choice. So with that, I will turn to my first panelist, Abigail Eichen, with my first question. So Abigail, given the challenges of the context that I have outlined above, there is more movement by women seeking abortion care to look towards services outside of the formal healthcare setting for obvious reasons. You've spent your career studying the safety and efficacy of abortion outside the formal healthcare setting. You have also shown evidence that a lot of changes that were introduced in abortion care in the United States during the pandemic, namely remote virtual care, have been safe and effective. Can you tell us about this work and, what inspired it?
Thank you very much. I'm delighted to be here with everybody today and to talk about this work. This work has been going on for me, as you said, for more than a decade, but for the past 5 years, I've been leading a project at University of Texas at Austin called Project SANA. That's the Self-Managed Abortion Needs Assessment Project. And I want to thank my many colleagues who are involved with me in that work. And, the inspiration for this work really came from two things. First, the needs of people who seek abortion, whether that's in the formal healthcare setting or whether it is self-managed abortion outside of the formal healthcare setting. Because I think we can see in the US context that even before the Dobbs decision and the overturn of Roe, the right to choose abortion was present on paper, but it was not a realizable right for so many people in this country. So self-managed abortion is nothing new. It's been around with us since there have been people. But what it looks like to self-manage an abortion looks different now to how it did even in the pre-Roe era for the United States because of more widespread access to medication abortion. And that's not the only way to self-manage an abortion by any stretch, but it's the one I'm going to focus on and talk about today, partly because the ability to self-manage with pills has become so much more widespread. And when we think about the needs of folks who are looking to self-manage, and this work is really informed by my own experience growing up in Ireland when abortion was not only unavailable, but explicitly criminalized. Um, and that experience has always informed how I think my team and I see the needs of people who are looking to access care. And one of the first questions that people often have when you talk to them about what they looked for when self-managing an abortion is this going to work? And is it going to be safe? Those are some of the first concerns. Will I be able to end a pregnancy? And will I be okay? So I think we have quite a lot of evidence from around the world that shows the safety and effectiveness of self-management with pills, but we really had very little in the US context. So Project Sana sought to fill that gap. And we did that with one of the main ways that people were self-managing at the time. The landscape has shifted a lot now, and there are a lot more ways in the US currently that people can access pills. But back then in 2018, a new organization called Aid Access began to provide abortion pills in the United States. That's an online organization where you go online, you fill out a form, it's reviewed remotely, and then the pills are mailed to your house with information about how to use them. And there's a help desk that you can contact for extra instructions or follow-up or any questions you might have about the process. Now, that's, again, by no means the universe of self-managed abortions with pills, especially not now. And even back then, it wasn't either. There are other ways, and there were other ways people were getting pills. But what's unique about Aid Access is the source of data that there was at the time. There is a complete set of data on how many folks access the service, and then there is follow-up information on whether or not they had a complete abortion, whether they needed to go and see someone in person to help complete the abortion, and whether they had treatment for what we would call a serious adverse event that would be bleeding requiring a blood transfusion or infection requiring IV antibiotics. So we wanted to fill this gap in the literature, partly to see what do the outcomes look like. My expectation as someone who had studied this in other countries was that we would see high rates of safety and effectiveness, but I wanted to see, does that bear out here in the US? And also for the very important reason that it has been the case that within the medical establishment, and I speak as someone who is trained and consider myself part of the medical establishment, quite a hill to climb in terms of removing some of the requirements that were in place for someone seeking a medication abortion. I'm talking about ultrasound, for example, to date and place the pregnancy, some blood tests, being present in a clinic and with a physician as you take the medication. And so this work, I think, also helped to reassure folks who are coming with a very medical lens that those things were not necessarily necessary and were in fact acting as barriers to people. So just to tell you, you can see the papers on our website, but we found rates of effectiveness for self-managed abortion with a 2-pill regimen with pristone and misoprostol, rates of effectiveness on par with those in the clinical setting. So if you were to go to a clinic and do this in the sort of formal healthcare setting way, vast majority of people are able to end their pregnancy, and that's 99%, I think, in our data, and 96% were able to do it without needing some intervention to help empty the uterus. Less than 1% were reporting treatment for a serious adverse event. So this is really important information for people who are seeking self-managed abortion, and it's also really important information for clinicians and services that are looking to set up ways to break down some of those barriers that in-person care requires, to feel reassured that we have some data on that. There are several other papers that I'll just let you look at on your own because I like to leave some space now for my fellow panelists.
Thank you so much, Abigail. And I can't tell you, how valuable it is to provide this evidence so that others, including others like Veronica, can do what they're doing and do it with some confidence that this is a safe thing to do. A lot of the links to Abigail's work is on the chat if people want to access those. So my next question is for Veronica. Veronica, you are an icon.
Mi siguiente pregunta es para Verónica.
You're an icon for reproductive health movement. You have created a large community movement in Mexico through your organization, Las Libres, building a network of women supporting other women through medication abortion in a time when the legal system was not on your side. Tell us about the origin story of Las Libres and what it took to make it successful.
Thank you. Thank you, first of all, for the invitation to Global Center and Social Responsibility. Thank you very much. It's an honor to be here with you sharing Las Libres. Very quickly, the first thing that makes us do this work is our own context of restriction. And today, it is very relevant. We are coming kind of back to 23 years. We already have overcome that. Now we're back to the same issues in another territory, like it's happening in the US. Guanajuato, the state where I was born, where we are Las Libres, with Las Libres, is a state that is in the central part of Mexico, and during that time was the most conservative state, the most restrictive one. Even that's how we burned from Las Libres, because the only way that there was a way to cause for abortion was because for rape. And the legislators during that age, they wanted to legislate and put women in jail, women of the victims of rape, if they tried to do an abortion, and they want to place them in jail for even to 8 years. And they say, we say it's crazy. We're not going to allow that. And I was already a trajectory in the militant movement in Mexico, and I got really upset. And I moved that mobilization, and we achieved something very important about a very complex topic, to make the population anger. The population was really angry, and there was the massive mobilization of people. People got out, and we achieved not the passing of this law, but we find out that women and girls victims of rape, not only in Guanajuato, but in anywhere, they were not taking the legal abortions, which they were made to have kids that were a product of rape. And that made us even more angry. So first thing that we did in year 2000, is create a network of doctors and obstetrics, and because that was the only way that we knew that we can guarantee the legal abortion and safe and free to women and girls that were victims of rape. However, since we were born in a public scandal, we were very public in us with all our reasoning and all our clarity. We decided to challenge the system. And we say, no, the problem that is illegal is your problem. You should guarantee the rights. And since you are not guaranteeing them, we are going to claim and guarantee them. So during that path, of course, we were working very publicly in the media, and people started to come to us and say, I am not a victim of rape, but also I want to have an abortion. And we say, well, it's the same thing. It's the same process, even if you are a victim or not. So during that path, abortion with medication is something that it was discovered, the women discovered, the Brazilian women in the 80s and 70s. So not until 90s, we get to learn about the first protocols of the OMS and about abortion with medication. So when we discovered this type of abortion with medication, when we read the OMS Organization of Health, World Health Organization. Sorry, we're getting a little behind here. So we learned about this medication for abortion. And that's what we found, this solidarity within the women from the very beginning of the humanity. So what we did was mostly organize ourselves, organize women to be sure that they have a right in the society when the states are restraining their rights, because they are not doing it, and they say it's abortion always have existed, and what we want is that those women who needed safe abortions wouldn't put their lives and health on the risk, and also their freedom. So that's how we started developing this strategy with women. Women were coming to us and they place in front of us their needs, and we organized the policy, non-state policy for women to guarantee the right of abortion, of safe abortion.
Incredible, Veronica. I get chills when I hear you, and it's so empowering to know the power of solidarity, and also the power of anger to move people into action. So thank you so much for sharing that. My next question is for you, Joanna. You and your colleagues were inspired to launch the organization Pregnancy Options Wisconsin after witnessing the dire need for accurate information on access to reproductive health, including abortion care. Tell us about this work and why it is particularly important for people in Wisconsin right now.
Absolutely. And thank you so much for including me on this remarkable panel. And greetings to my Minnesota neighbors from Wisconsin. So we started Powers prior to two big things, prior to the COVID-19 pandemic and prior to the Dobbs decision. So in 2018, 2019 in Wisconsin, abortion was legal, though very, very difficult to access based on a variety of very restrictive laws that limits things like who can provide abortion care, as well as requiring at least 24-hour waiting period between two in-person appointments. Additionally, there were only 4 clinics in our entire state that provided medication and procedural abortions, compared to probably about 80 so-called crisis pregnancy centers or anti-abortion centers that purported to provide medical care and information. So Powers was founded by a kind of ad hoc group collective of community-based midwives, physicians, doulas, nurses, and community activists who wanted to provide an alternative to those fake clinics, crisis pregnancy centers, and provide a full factual buffet of information about all reproductive options that are legal in Wisconsin. That included providing really comprehensive information about the legal restrictions in Wisconsin and how to navigate them. And so a lot of our work takes place via our website, which is really comprehensive, including information about options for continuing pregnancy, birth options, adoption clinics if people choose to make an adoption plan, as well as options for releasing a pregnancy through abortion, whether that is self-managed or through a medical professional. However, since the Dobbs decision, Wisconsin is now living under an 1849 abortion ban that criminalizes the providing abortion. So we are having to assist people with looking at what their options are for abortion care. And that includes traveling to our neighboring states of Illinois and Minnesota, who have taken really strong steps to prevent or to protect access to abortion care. So our call line, we have a call and text line that provides support for people to help them navigate their options. We provide support for all pregnancy options, but the majority of folks we're hearing from, especially since the Dobbs decision, is people who need help getting to our neighboring states to access abortion care. So we help people with things like assistance with funding if they need funding to help pay for their abortions. We also assist with coordinating things like travel, finding a clinic, and then we also provide emotional support if that is something that people are seeking through the process, as well as being a safe place to call if someone is self-managing their abortion and has questions or concerns.
Thank you, Joanna. I mean, the service that your organization is giving is tremendous in this time of need. And we have put a link to your website here in the chat as well for people if you wanted to read more about this work. And actually, in light of that, what you just said about resources, I'm gonna pivot to Abigail a little bit. Abigail, you kind of mentioned Project Access briefly in your initial response, but can you say a little bit more about the resources that people in the US are using to access care in states that ban abortion in the US? And, you know, are there any signs that change is possible to restore reproductive freedom in the states? Tell us a little bit about that.
Yes, I think that right now there are several ways in which people are accessing information in several different categories. So I think when people are looking for sources of abortion pills, one of the main places they are looking is the Plan C website. I don't know if folks out there know about Plan C, but they have done a lot of work looking at different avenues for obtaining abortion pills, be that through online pharmacies or organizations like Aid Access that provide an outside of the formal healthcare setting telehealth type model, community provision based in local communities, cross-border pharmacies, and then of course Las Libres that we have the pleasure of having the founder of here today. I'm just fangirling over here a little bit, excuse me. But we know that a lot of folks, you know, are going to want to know information about pathways before they might trust or they might feel comfortable with different models of self-managed abortion. And so Plan C has done the work of ordering from various different websites and services and are able to provide information on things like shipping times and cost and what kind of information is part of the model that someone might access. For some of the online pharmacy sites that don't necessarily have a face of the organization, people often want to know, is what I'm going to get going to be real medication? So Plan C has ordered the medications and tested them, for example. So a lot of good information there. There's also ReproAction, the M&A hotline for information and support around self-management. People are sharing this a lot on social media. So there are TikToks about self-management, there are Reddit forums, there are all kinds of ways in which people are now disseminating and sharing information. Another aspect is legal help. So increasingly, we are needing to be aware of potential legal risks. As a person that, of course, studies the safety and effectiveness of self-managed medication abortion, I often say the biggest risks to people are not medical risks, they are legal risks. And just because a state does not have a law on its books that would explicitly criminalize self-management, there only are 2 such states, it doesn't mean that there are not attorneys general or prosecutors who are willing to surveil and harass and unjustly prosecute people using pieces of legislation that are not intended to mean anything to do with abortion. It has happened. It will continue to happen. So there is an organization called If, When, How, Lawyering for Reproductive Justice. They have a legal helpline for information as well as people who suspect they might be being surveilled or have had contact around their self-management experience. So many sources of information, and these are growing. I think one of the unintended consequences of abortion restrictions, and I say unintended from the perspective of those who would wish to advance those restrictions, is that they do actually shine a light on self-managed abortion. They create the necessity for people to look for alternative models of care because they don't do anything to address the need for abortion. They don't do anything to help people who might otherwise choose something else, which is of course not everybody, but there are some people in that group. And so what they do is they shift the locus of where people are looking for care. And that then means more people become interested, more people hear about self-management. And interestingly, in our research, we definitely find a big correlation between increasing abortion restrictions and more people looking to self-manage. because of barriers, but we also find people for whom self-management is their preference. They wish for the privacy and the comfort and the autonomy of managing their own abortion. And they're increasingly looking to states where people are getting actually a very similar experience, because now with the FDA's relaxing of the REMS restrictions on mifepristone, we see abortion pills being mailed as part of normal care practices in many states in the US. And people, for example, in Texas or other states where there are restrictions, are looking there and saying, why don't I have the same right or the same ability to do this? So self-management is a response to barriers, but it can oftentimes be a preference. And I guess to your question about, is change possible in restoring reproductive freedom? I think we're seeing it. I think the thing about self-managed abortion is that you cannot take that from people's hands. There are many, many ways in which laws and policies in this country can attempt to dissuade people or attempt to stop them accessing things, or even attempt to chill them and those around them with threats, legal threats. But it's incredible how people will find a way. I say this from my own context in Ireland. I say it from looking around at the global picture. Self-managed abortion in many ways is the ultimate in reproductive autonomy and freedom. And I think history shows and tells us that you can try to oppress people, and of course you can succeed in many ways, but you cannot ultimately stop people from doing something that they really, really, really need and want for themselves to do. And so I think we're going to see a lot of attempts to do that, but it is my belief, having lived through this context and paid attention to it worldwide, that we are simply, people will find a way.
Very well said. And of course, Veronica and her work is a testament to that, I would say. People will find a way. And I want to kind of ask you a question, Veronica. I mean, as you're looking at what's happening in the US, I'm sure this is becoming more like a deja vu, and I'm sure it's pretty painful to watch. But however, I want to know, do you have advice for advocates of reproductive health in the US on how to proceed? And actually, also people who seek abortion care. I feel like the beauty of your work is the community mobilization and the solidarity among women themselves. And in a country like the US, people are very individualistic, and even the word self-managed, it kind of gives you the impression the individual woman does it for herself, whereas your model is actually having other women accompany women and make them feel safe and give them information and support and whatever they need. So what are advice for advocates and people who are serving this community?
Yes, perhaps following what Abigail said, it really works to explain a little bit. Of course, I cannot give a lot of details because for safety issues, but in general, how is the access to women of those restrictions in the US? Las Libres, what we're doing is sharing a model, like Abigail said, that is working, that is not going to stop from working, that the restriction, what they do is just increase the finding other ways to deal with in other ways. And what I really like and it passions me in the US is to see the struggle, the fight from the communities, the society, the society organizing, because it's not so against abortion. Everybody goes to a clinic. No, what the idea is the restrictions that they are making the society to think about in the United States, which, in particular, how we can fight for the universal access to abortion and for everyone and everywhere in the world. And each person decides. And what we do in this model is exactly that, accompany them to the reproduction decisions, and is to mobilize the population to help to accompany socially these women, and also to advance and overcome the legal restrictions in the decriminalization of the abortion. In the case of the United States, it's a very specific and special because the stigma, the high stigma about abortion and about people who have abortions in that territory, in territories which the laws are very restrictive. But to give you an example, what we're doing is how we're doing mobilizing the society in a year, just a year. And that's another thing we have to say. Mexico and Latin America, we have a lot of years because of the restrictions doing a big movement of accompanying and with political movement. Is not only like, like social assistance that we resolve as an aid to women's problems. It's how the society involves more actively, where in which the people that are enacting the laws are restricting it. So a quick example of what we're doing in a year, the good news is that there are 4 logistics that we have developed in a year, because the reality is always changing. And when we decide, we have to respond, right? One is, as you know, in Mexico in year 2021, the Supreme Court is stated that is unconstitutional the abortion in all the United States, Mexican states. And we have all this accompanying in all the Mexico. When we saw about Texas in September, we share territory. People come and go in both territories, you know. So we develop in a year 4 logistics. When women cover the cross the borders, they buy their medication, because in Mexico there is no restriction to misoprostol, and they come back. And then from Guanajuato, we're giving them all the support for the procedure. The second one is women, of course, that can cross the border, and we place them in contact with accompaniment cities. We give them the medication, we accompany them. And the third logistic is also for women who are crossing the border. We open up some safe spaces that we'll call the aborterias, like places for abortion that are safe spaces in which women can come. We give them the medication, the accompaniment, and the whole process. And then in this, of course, the space with all the resources, everything for free. But the vast majority of women, as Abigail say, the vast majority of women cannot cross the borders. So the restrictions are the women are more affected. So those are the ones who cannot cross the borders, are the ones that we have to develop a lot of strategies to how to make those medicines to come to them. So that's the good news. So the population of the United States, like that, because the organizations, for obvious reasons, were very afraid to start doing this work of delivering the medication. It was the population, as Abigail said. They read an article in the New York Times. They wrote to us and they said, there's money here to buy the medication. Other people say, I'm ready to bring the medication. I'm going to take the training to do accompaniment. And a year is impressive. More than 10,000 women we have been accompanying in this restrictive territories. More than 300 networks exist in the US in a very organic way, and everything, all the money has come from the society with all these resources. And that's very important. Mexico has always seen the United States as a model to follow in many things. And now Mexico, I am very proud to say it, I feel very proud that they're helping women in the United States, especially a country who is considered as a poor country. We're doing it for free, because everything costs, and abortion is expensive, especially in the United States. So it's very important to remove that overburden from abortion, because women with less resources are the ones who are going to have less access, because sometimes don't have a penny. And that's how this is very important to do a mobilizing work of the society and politics. Also, when we give the message to the society that the reason is on our side, the restrictions or no restrictions, we have to overcome them. But we have to be able to resolve the issue within the whole society. And that's all what we're doing. Organize ourselves, organizing the community to resolve an issue well, the state decides to guarantee the rights of women who need abortion, because health is what it is, it's a universal right. The more important that United States has not signed international covenants, and this is access of universal access that we all women have.
Mhm.
So we all have that.
Amen. Oh, that's such a heartening message. And, truly, I think this work is a testament to the universal nature of the human condition, and also the compassion and empathy and willingness to help each other. This is just incredibly inspiring. It's actually also brings me to my last question for Joanna, which was, even within the United States, there are states where abortion is legal, and we're able to do it well, and how those states can help other states that are struggling. So I guess, my question for you, Joanna, is, since you've been assisting women in Wisconsin seeking care in other places with at least information, do you have any call to action in neighboring states like Minnesota, where abortion care is illegal? How can these communities and these neighboring states organize to address the unmet needs, such as transportation, housing, and even accompaniment? I am particularly concerned about communities who can't afford a lot of those, even if neighboring states are providing that care for free, getting there might be a big challenge. So any call to action to states like Minnesota, what we need to be doing more of?
Yeah, absolutely. So the first thing I would say to our neighbors is the thing that you have already done, which is remarkable, which is organizing and voting and getting people out to protect access. The simple fact that somebody who is in Wisconsin, where it is illegal to access this care, can cross the border to a state that has now codified this as a protected right and has done amazing things with improving your laws to increase access with things like getting rid of parental notification, getting rid of the 24-hour waiting period. Those things make a huge difference. So please keep doing that because it's not just for your state, it is for the states around you. You've become a central hub for the Midwest for this right. Another thing that you can do within your state that supports those of us in Wisconsin is supporting your local abortion funds. So local abortion funds provide financial support to folks who are seeking clinical abortion care. And so if they are supporting, your local clinics through the local abortion fund, it is likely also supporting people traveling from out of state. And in fact, our call line works really closely with Minnesota abortion funds to help ensure that continuity of care and financial access for folks traveling from Wisconsin. Additionally, there are a couple organizations that do some logistical support that I want to lift up for people. One is the Midwest Access Coalition that provides financial resources for folks who are traveling for abortion care in the Midwest for things like paying for transportation, lodging, food, really basic stuff like that. There's also a really innovative group that I am really into called Elevated Access, where folks who are pilots who have small planes, like little 4-seater planes, can volunteer and directly transport people via their small planes out of Wisconsin and to Minnesota or other states. So getting involved with those organizations. Another thing for people who are interested in companioning is to learn more about becoming an abortion doula, which is a newer, the title is new, but the concept is ancient, of people companioning each other through all pregnancy outcomes. Oftentimes there are either clinic-based programs to support people in the clinic through the process, or there are some independent organizations. Here in Wisconsin, as a model, we have a group called the Wisconsin Abortion Support Network, which connects trained abortion doulas with folks who are seeking abortions to provide support for free. So that's another really great way. And I would say connect with your local providers. They are the experts in what their patients need and what people are telling them they need. There's opportunities, I think, for connecting with people, connecting with providers for things like what I've heard called the last mile. So we may be able to get somebody to the airport or the bus station in Minneapolis, but we need to get them from there to the clinic or from there to their hotel. There's also really great models. I think there's a model in New York City called the Haven Coalition, which provides housing for folks who are traveling from out of state for abortion care. And that's something that I think there's a potential for replication for as well. And then my last thing I always just want to uplift is to take pride in your status as an island of access in the Midwest. I think that those who oppose our autonomy and our reproductive freedom really, they are the ones who have the most to gain from our silence and from our shame. So for places like Minnesota and Illinois to be loud and proud about the fact that this is a place that supports autonomy, supports access to reproductive health care, and is a place that provides safe abortions, can really help change the narrative and help uplift those of us who are in states that are dealing with these bans.
I love it. And you mentioned a lot of organizations that are doing some great work. Joanna, is this information available on your website? If we direct people website, in case folks attending want to support some of those organizations?
Yeah, I think most of that should be available on our website. I don't believe the Haven Coalition is, but yeah, I'll say their name again, Haven Coalition, that you could Google as a model for communities that provide lodging for folks seeking abortion care.
Awesome. Thank you so much. Before I go into the Q&A, which I'll do in the next minute or so, I think that was a really fantastic call to action, Joanna. And Veronica and Abigail, if you have to say one thing for a call to action for people, what would it be? Abigail, do you have something right off the top of your mind for a call to action?
I will do this with my researcher hat on, which I think is to say that there are many things we still don't know and wish to know about people's needs around self-managed abortion and how different laws and policies are affecting them. And so, we are welcoming research in this space.
Awesome. And Veronica?
Yes, I would like to say that being afraid cannot paralyze us, because if we get paralyzed, they are winning, the ones that don't have the right. And the right is helping us, because that's all we are doing. We're accompanying the personal decisions that a person, you cannot make another person, you cannot tell somebody else how to live or how not to live. And as a society, we need to win the restrictive territories, only organizing us socially. That's how we're going to win.
Thank you so much. This was a fantastic conversation. I can't thank you enough. I'm going to pivot towards some of the questions that are coming from our audience. As I mentioned earlier, we're going to go until 1:15 with this programming, but I know some people might have to get off around 1. So we will put some information on the chat box about opportunities and ways to support in case you have to leave early. Also, we'll put a link for a survey just to get your feedback on this programming. If you can fill it out, we would really appreciate it. This is information we'll share at the end as well, but we don't want you to miss it. So with that, let me see. I think this first set of questions, I'm going to try to compile it into one from multiple people. And maybe Abigail, it looks like you may be the right person to answer. And it has all to do with legal situations and concerns about access to care. So the question in general is, can somebody from a state with abortion, where abortion is restricted, order pills to self-manage from a state that allows it? Is cross-border shopping of medications, like say from Canada or Mexico, is that an option? Which kind of relates to what Veronica was saying a little bit. And then finally, is self-abortion, what happens if the pills are outlawed? What happens next? If you have any thoughts around that.
Thank you. A great set of questions. So in the first part, I think in terms of whether someone who wishes to self-manage can obtain pills from a state that allows it, that is not something that is currently really ongoing, because, let me sort of explain this. If you were to look at a state where abortion is allowed, right, either in general or through telemedicine, most of the organizations working there, and there are some great ones, Hey Jane, Just the Pill, Choice, Abortion on Demand, they are providing within their sort of scope of clinical practice. So if they have physicians that are licensed in the state where they're providing, those physicians are generally going to be restricted to providing where they are licensed, right? So if you're sitting in Texas, it's not going to be possible for you to directly order pills from a telemedicine service like that. They don't provide there right now. But there are some states that are considering what are called shielding laws. And those are laws that would, I believe New York is an example of this right now, that would protect clinicians who are licensed in a certain state and want to provide care to people in states where abortion is banned from the effects of those abortion bans, right? Because most abortion bans are written to criminalize and punish the providers of abortion, right? And so if you were sitting in a state like New York and you tried to provide abortion pills to Texas, you may be found liable under Texas state law for having violated Texas state law. And the idea of a shielding law is that it would protect you from that kind of legal jeopardy. So in general, the answer to that is no. The next thing, cross-border, yes, definitely. So a lot of the online pharmacies you will find, if you just Google and look for them, are providing from, some are based in Canada, some are based in other international settings, and you could go across the border and look for pills in Canada as well as in Mexico, which of course people do frequently. And finally, the bit about whether, well, yes, if self-managed abortion pills are outlawed, what next? This kind of comes back to what I was saying before, where I don't right now see a way in which self-managed abortion pills can be outlawed. And the reason for that is because many of the organizations that are providing and helping and supporting people are based outside of the US, and quite often there's a lot of questions about whether people in those territories and organizations in those territories are subject to those laws, or even if they might be, how to make that happen. That's something that we've seen in many other settings, does not happen. And then there's the question, I think we're seeing the movement towards the idea of prosecuting people who self-manage for a reason, right? Because there really aren't many ways to contain self-managed abortion. And I think that that's becoming apparent to folks that would like to do that. And they are moving towards a very new rhetoric for that movement, which has always been, but we don't prosecute people who have abortions. We don't harm women. We want to help. We don't criminalize. And I think that that is perhaps causing some divisions right now, because some attorneys general and some legislators are indeed moving in that kind of direction. South Carolina is an example. The Attorney General of Alabama is an example right now. And so this idea that if you criminalize the person who self-manages, that's going to stop this from happening is prevalent right now. I have to tell you, certainly coming from the Irish context, that has never been the case. Self-managed abortion has been explicitly criminalized in Ireland and Northern Ireland from as long as anyone can remember, up until 2018 when the abortion referendum happened, and still 5 Irish people a day self-manage their abortions. Now, what that law does is it can isolate, it can harm people, it can make them feel, I'm not saying that it's not a problem if this happens, but at the same time, I don't believe it's an effective strategy from a policy perspective for stopping self-managed abortion. And I want to pass to Veronica because I know she's going to have more to say.
Veronica, you want to weigh in?
¿Quieres decir? Yes, exactly. Right now, for example, in the case that, in the case how technically the focus is not on people who are abortion. They don't want to criminalize the people who's having abortion, but the people who's helping them. In this way, for example, if we are in Mexico, we're trying to help somebody, sending the pills to somebody in Texas, is all this topic about extradition and all that. But right now, like Abigail, there isn't really since from my point of view, the restrictions that they are in the United States have all the intention of to scare people. They are trying to make examples on people to prohibit or restrict people. But like Abigail was saying, abortion with self-managed pills, everybody has to know that it has to be safe, that is safe. That the misoprostol is only 85% of effective. But what I'm trying to say is that people who are questioning their self-abortion are going to try to get the medicine and the correct information. Really, not very many people are going to have to go to a hospital. And why is that? Because this is a very routine process. They don't even have to be a bed rest or anything like that. It's like having a period, a regular period that you have. So that what it means is that, in fact, that a person, if she doesn't want anybody to find out about this, nobody's going to find out. Nobody is going to find out that she had an abortion if she doesn't tell anybody. And if this process is the support that we give to her, so she doesn't feel alone. So even though we're not physically with her, so she just doesn't feel that she's alone, and we are with her in her decision, and this is going to be safe. And whatever emergency or event that she has, we're going to be there with her, and we're going to resolve her problem. This is very important when you are in a restrictive territory. But another thing is that this social movement, nobody can stop it anymore, because when people is also helping, and they see that they're helping to resolve a concrete problem with a very complex problem, nobody can stop it anymore. And that's the guarantee of feeling safe, how we are protecting each other to be able to guarantee the access. And that's a way that I don't doubt that in the United States, they're going to make an example of some cases, and they're going to start having restrictions, of course, because what they want is that they want to stop people to have abortion. But that's not going to, restriction is not going to stop that people stops their abortion, but the restrictions is putting people's health in risk, really, and that's what's going to happen.
Yeah, definitely. I mean, sometimes necessity is the mother of all inventions, right? People come up with even better ways of taking control of their own reproductive health freedom when they're faced with this kind of issue. Actually, just before, as you were talking, Veronica, one of the other questions is kind of in line with this is there any danger of government persecution of people who assist with abortions in Mexico, particularly, for people who are coming from outside into Mexico?
First of all, we say in the case that everything is happening in Mexican territory, not anymore, because the crime in all territory has been is unconstitutional. So what does that mean? That any person who have an abortion, or the person that we accompany, the services, health services, they cannot be criminalized for helping or for assisting or accompanying an abortion, all in all Mexico. Now, related to people that are Mexican, we as population are helping and supporting and accompanying the reproductive decision of women from other countries, for example, in Texas. We don't know. We don't know yet those limitations or these legal issues. Of course, we have an idea that they could try to find grounds, in the lawyer's law world and create crimes. But from our perspective, from our experience, from our own understanding of the accompaniment of these reproductive decisions, there is not a crime.
Thank you. Thank you so much. And you did mention Texas, so that brings me really nicely to a question that maybe Abigail, you may be able to answer this about, of course, you're aware of the Texas decision regarding mifepristone. And, the question is your organization preparing, how are you preparing in anticipation of that decision? And what happens if they block the use of mifepristone, or what are your thoughts around that at this point?
Thank you. Yes, we have prepared by researching the misoprostol alone protocol. So as we talked about at the beginning, the regular or most usual, but not always, most usual in the US regimen for medication abortion is mifepristone, the first pill, followed by a set of pills that are misoprostol. But it is also possible to do a medication abortion safely and effectively using just the second set of pills, so misoprostol alone. We did a study, it's just recently come out, you can find it on our website, looking at people who self-managed using misoprostol alone in the United States, because there was really a dearth of data. There's a lot of good global data that's showing the safety and effectiveness, but there wasn't really much US based. So we produced that study and published it with thankfully good timing. So that is out there. We found slightly lower effectiveness. So that means that out of every 100 people that would use the misoprostol alone regimen, we found that 88 of them were able to complete their abortion without seeing a healthcare professional to help end the pregnancy using a procedure like a D&C. Whereas with the combined pill protocol, the two pills, we found 96%. There's a range of what you see out there, so it's a little bit less effective in our data. Some studies are showing effectiveness, though, that's up in the 96% range. I think it depends on the context that you're in and how much misoprostol you have available to you, because one of the ways that you would manage an incomplete abortion, even with the two-pill regimen, is by giving additional doses of misoprostol. So there's a lot of variation around that, although in general, we say it's slightly less effective, but it's still very safe. It's still something that people could access even in the absence of mifepristone. And it may be what clinical providers in the US pivot to if we do see approval for mifepristone disappear. Self-managed organizations, though, may do a variety of things. They may stay with the two-pill protocol or may decide to provide only misoprostol, depending on what they decide to do. I just want to finish up by saying, though, that even in the case that we do see a ruling in favor of the plaintiffs, that does not necessarily mean that mifepristone is going away. I want to make that clear because oftentimes I think that's not necessarily a big part of the coverage we're seeing out there. The FDA has options here. They would have to institute a process to basically de-approve, and that will take some time if they decide to do that. They don't even have to do that, though. They could also decide to appeal the case. They could also decide to reopen a new approval process, which might be a good thing because there are still some restrictions on mifepristone that actually are, based upon evidence and people's needs, unnecessary. And it's possible that the case could not have this wide-reaching effect of banning mifepristone nationwide that I think it automatically seems as though it would have. So really watch this space on that one. But in the very worst case scenario, misoprostol is there, it's safe, it's effective, and people will be able to access that too.
Wonderful, wonderful. And Joanna, I know you've been kind of quiet because I've been throwing questions at Veronica. One of the attendees said if they were kind of wondering if you've heard of the organization Spiral Collective. They say it's a grassroots reproductive support organization in Minneapolis, in our city, and offers abortion doulas. And they're just kind of curious if you have some sort of collaboration with them.
So now that it's being said, yes, I have heard of Spiral Collective and I forgot. You can tell I'm kind of focused, like my Wisconsin focus. So again, that's another great option of a community-based solution and community-based option for providing support to folks who are coming from, all around your state as well as from out of state to provide care and companionship to folks going through the abortion process. So yes, Spiral Collective, go look them up and maybe give them some money.
Great. And the last question is actually, the person says they really appreciate the fact that Veronica talks about all people in her Las Libres model, inclusive kind of movement. And they're curious to know whether in your organization as well, Joanna Powers, or in the work that you're doing, Abigail, if you make a concerted effort to be inclusive in your work, gender, sexual inclusivity, and can you say a few words? Maybe Joanna, I'll start with you.
Yeah, I think that's a great question. And I think that's a really, really important consideration for, especially when we're talking about reproductive health. One of the things that we have done from Powers since the very beginning, and I always say our core organizing principle or motto or mission statement is to trust pregnant people. And we use the language of pregnant people very, very intentionally to recognize that not only can women experience pregnancy, transmasculine folks can become pregnant, non-binary folks can become pregnant. I think also I had heard what I think is a really important thing to remember is that children who are assaulted can become pregnant, and it's really unfair to equate a child with a full-grown woman. And so we believe in centering the pregnant person as the moral and ethical authority on their lives and their body. And so we do strive to be as inclusive and welcoming as possible. And in part of that is even screening a lot of the resources that we refer to, including, like I mentioned, we have information for folks who are considering making an adoption plan if they continue their pregnancy. And we make sure we are only sharing information about vetted adoption agencies that work with folks who are LGBTQ+, and are welcoming to folks of all religious or no religious background, because we know that a lot of adoption agencies really are limited that way. So yeah, that's what we are trying to do.
Wonderful. That's fantastic messaging around communication for sure, and inclusivity. Abigail, if you have a few things to say about that, but I actually have one question for you that might be even more relevant for you before we end. This is a question that was sent to us even before this panel discussion by one of the attendees. And they said, where would you tell researchers aspiring to amplify and engage the community-based health literacy efforts to start? So basically people who want to be you, Abigail, and kind of but they want to engage the community in the research efforts. Do you have any advice?
Yeah, okay, let me see. I wanted to say something about both, I think, just really quickly. First of all, is to say that at SANA, we have a diverse team, which brings us a lot of different perspectives when we approach this issue. And we are intentional in our language also when we write research papers and when we do our policy and public facing communication, talking about people and also defining what we mean by people in papers. We lay that out where we can because we think it's important to be inclusive in this language. We also in our research have heard from a diverse variety of people. And oftentimes in our qualitative interviews, in our quantitative data, we do ask questions about gender identity, about sexuality, and we are mindful of whether or not we are reaching people and including them in our research. I'm happy to say that we usually do have representation from gender diverse individuals, but we can always do more, I think, to help create a welcoming space and to let everybody know that their voice is valued. That's one of the most important things I think about our research when we are trying to do research that will inform policy, is trying to bring in the voices of people who may not have an opportunity to talk with legislators and people with power in any other way. So we take that very seriously. And then in terms of amplifying, engaging with the community, I think there's actually a lot of research to do around this. I think that, we have been focusing very much on a model of self-managed abortion that depends on a certain level of health literacy. And we've done that partly because that was, as I said, it accesses a very unique source of data. It's something that even very early on gave us this window into self-managed abortion in the United States. But we're also very aware of its limitations in terms of people who may not, be able to get online, or people who may look at the consultation form and think that is too much, or, may not be able to understand everything that it's asking of them, or may not want to share that kind of information. And so I think there's a lot of research to be done around perhaps who is maybe not well reached by various different models of care. Of course, I think community-based models probably play a really important role in reaching folks who may not be able to engage with online efforts. But I would say there's actually a big space there in terms of research, in terms of understanding those kinds of needs. And so that's where I would start, honestly, is in trying to figure out what do people need and want from us, and then how can we work to fill some of those gaps.
Thank you so much, Abigail, for that. And for just to add to that, I would say there are some really great models of community based participatory action research that can be done to engage communities in the research as well. And there are some organizations in the Twin Cities. One that comes to mind that I have collaborated with is called Salamo. Actually, it's at the Community University Healthcare Center. That's where they're based out of, and they engage many different communities in actual research. So for those who are interested, look them up. So this has been incredible. Thank you so much. I'm gonna do like a few wrap up things here before we end. We really appreciate people attending this. I wanna tell you about some of our Global Health Centers opportunities coming up. We have a seed grant that we do annually actually, and we wanna share an opportunity with you as people who are invested in women's health. Each year, the Center of Global Health and Social Responsibility offers our Global Health Seed Grants, which are awards up to $25,000 to catalyze innovative and collaborative global health research projects. This year, in addition to the annual Center Global Health Grants, there's actually a special interest call for research projects specifically pertaining to women's health. So we hope you will apply. The letters of intent are due on April 28th, and you can learn more about this on our website, and this will be in the chat for you. The other thing is just a call out to you also to support our center. If you found this kind of programming informative and engaging, our center is dedicated to continuing to make a positive impact on local and global health, in particular in the areas of health equity for women, both globally and locally. And we couldn't do this without the support of individuals who are passionate about improving health worldwide. So if you believe in this mission and vision and want to support work like this, feel free to contribute to make a gift to the Global Women's Health Fund. And it would be, the link to that will also be in the chat for you. This fund supports actually capacity building efforts internationally and locally, and engagement in the educational activities and training of our healthcare professionals as well. So thank you for your consideration and support on that. And then we have a final ask for you who have attended today to kindly fill out the survey, as I mentioned earlier, for your feedback on today's webinar. Your responses will help us plan and improve on future programming. So thank you to the panelists. Thank you to the audience members for joining us, and thank you to our WHEEL Consortium partners for this collaboration in this series. Thank you.